Everyone. Today in this video, we are going to discuss about the chest X-ray interpretation in pediatric population. In my previous video, I had discussed how to describe and how to diagnose any disease or how to interpret a chest X-ray in pediatric child. In this lecture class, I will discuss what are the diseases and how to diagnose a disease from the chest X-ray. So let's start with a first chest X-ray. So this is a skygram of a child taken in epi view, and there is a showing that the rib cages are the density of the rib cages more whiter. That means there is a much more white bones, and all the bones are much radio opaque. So there is a radio opaque bones with higher density of all the ribs. So this is a diagnosis of osteopetrosis if all the rib are normal but the lateral end of the bones are having radio opaque shadow. There is a white density on the lateral end of every bones, then it is a Caffey's disease. But in this case, there is a white density is more in every bone. So it is the diagnosis of osteopetrosis or marble bone syndrome. Now next, this is a skygram of a chest taken in epi view with a proper exposure and small rotation of the X-ray is happening, and rotation on the right side is seen. This X-ray shows that there is a crowding of the ribs on the right side. So this is left and this is right. So there is a crowding of ribs. So these ribs are crowding. There is a crowding of ribs, and there is a white homogeneous opacity throughout the right side, starting from the upper end to the lower end of the chest field. So there is a wide dense opacity, homogeneous opacity throughout the right side with crowding of the ribs. So the diagnosis is mostly it is a diagnosis of lung aplasia or agenesis. If in this X-ray showing bronchoscopal markings, then it is a collapse with patent bronchus. But in this scenario, there is no bronchoscopal markings are seen, and also there is no air bronchogram is seen. So if the air bronchogram is there and the bronchoscopal markings is there, then it is maybe a diagnosis of collapse consolidation with patent bronchus. But there is no bronchoscopal markings and no air bronchogram is seen. So it is a diagnosis is there is an absence of lung on the right side, and there is a hyperinflation of chest as because the diaphragm is flat and there is the gap between the ribs are increasing, and there is a 1 2 3 4 5 6 7 8 9. So more 9 ribs are crossing the dome of diaphragm. So this is a hyperinflation of the left side. That is a compensatory hyperinflation of the left lung. Now this is a skygram of chest taken in epi view, which shows there is a air fluid level in the left side. There is a air fluid level on the left side, and the heart shadow is shifted to right side. So this is a diagnosis of diaphragmatic hernia. This is a Bogdala hernia. Why? Because the dome of diaphragm, integrity of the dome of diaphragm is breached, and the gut things is going up to the lung left side, and there is a pushing due to this gut. It is pushed the mediastinum to the right side. So it is a diagnosis is left-sided diaphragmatic hernia. Next, so this is a skygram of chest taken in PA view, which shows the normal, no rotation is there, and the exposure is good, and it shows all the rib cages are normal, the clavicle is normal, and costophenic angle and cardiopharyngeal angle is normal on both the sides, and the trachea is in the midline. There is no shift of trachea is there. The right-sided lung field shows there is a patchy infiltrates and increased bronchovascular markings throughout all the lung lobes and all the zones. So this is the medial, this is the middle, and this is the left. So increased bronchovascular markings throughout the all the areas. So in the apex, there is an increased bronchovascular markings is there on the right side, and there is a heterogeneous white, and there is a heterogeneous white opacity on the right lower zone and also the middle and upper zone. So there is a patchy white opacity throughout the right sided with there is a, so he is showing air bronchogram. This is the air bronchogram with the air bronchogram, and there is coughing and puffing of the bronchovascular markings at the hilar region. So this is a clear diagnosis of bronchopneumonia, and the cardiac shadow is also normal in, and the cardiac shadow is less than 50% of this, and the bronchus is in normal position. So this is a clear-cut diagnosis of bronchopneumonia, as there is a patchy opacity throughout the right sided. So right sided bronchopneumonia, left sided lung field is normal, the hilum region is normal, and bronchovascular markings is not going to the lateral 1/3 of the lung zone. So this is right sided bronchopneumonia. Why? Because there is a patchy opacity throughout the lung, increased bronchovascular markings, there is a air bronchogram is seen, and there is a coughing, puffingness of the hilum region, bronchovascular markings, and also there is a patchy opacity, and this patchy opacity due to the atelectasis of the end of the terminal bronchioles, which is supplied by the bronchus. So this is one air bronchogram. If we zoom it, this is one air bronchogram. This is bronchovascular markings. So this is bronchopneumonia. Next, this is diagram of chest taking in PA view, which shows underexposure, and also all the rib cages are normal, clavicle is normal, the costophrenic and cardiophrenic angle is normal on bilateral side, the trachea is in the midline, and the cardiac shadow is normal. There is no cardiomegaly is there, but there is the left sided lung field is quite normal. The hilum region is also normal, but there is on the right side, on the lower lobe, there is a homogeneous opacity present. There is a homogeneous opacity in the present on the lower zone, and with a prominent with bronchovascular markings is present. So, but the mediastinum is not shifted, the trachea is in the normal position. So this is a like a diagnosis of lobar pneumonia on the right lower lobe and the middle lobe. Why? Because in the lateral X-ray, it is, as I say, it is T2. So T2 to T6 ribs, sorry, T2 to T6 ribs major fissure, and T4 to sternum minor fissure. So this is right upper lobe, right lower lobe, and middle lobe. So right lower lobar pneumonia and also the middle lobar pneumonia, because the whitish opacity, homogeneous opacity is present. Why not? This is a lung mass, because there is a bronchovascular markings are present, and the increased bronchovascular markings are present throughout the area. So as there is an inflammation, so this is the bronchovascular markings. This is the AR bronchogram is there. As this is there's a clear cut margin is there, and also there is a increased bronchovascular marking. So there is a inflammation. As the inflammation is going on, so there is increased bronchovascular marking. So this is the clear cut diagnosis of consolidation. Why not? What are the differential diagnosis of pneumonia, lower pneumonia? There may be a collapse consolidation, there may be a fibrosis, there may be a mass, there may be a fluid. But how to differentiate from this to pneumonia? As the trachea is as the trachea is in the midline, the mediastinum is not shifted, so there is no fibrosis or no collapses there, and the rib cages are normal. There is no crowding of the rib cage. Why not lung mass? In lung mass, there is a no bronchoscopal markings is seen, but there is a bronchoscopal markings are seen. So this is a like a diagnosis of pneumonia. Right-sided lower and middle lobar pneumonia without any parapneumonic effusion, as because there is a the angle is acute, so there is a no parapneumonic effusion. Now next, so this is a scagram of chest taking in PA view, which shows that all the clavicles are normal, the rib cages are normal, the angles are acute and normal, and the cardiac shadow is also normal. No cardiomegaly is there. The left lung field is normal, and the right lung field showing there is a homogeneous opacity involving the middle and the lower zone. So this is a there is a bronchoscopal markings is there. So this is without any mediastinal shifting. The trachea is in the normal position. So this is a clear diagnosis of right, middle, and lower lobar pneumonia. Now this is a scagram of chest taking in proper position with a rotation towards the right side, and there is a small break of the clavicle, but it is not that significant there, and there is a the exposure is normal. This X-ray shows there is a the rib cages are normal and the trachea is in the midline, but and the cardiac shadow is not well demarcation is there. The right side there is a patchy white opacity, heterogeneous opacity throughout the middle. This is the upper zone 1, this is zone 2, this is zone 3. So there is a white patchy opacity throughout, heterogeneous opacity in the zone 2 and zone 3, and there is the costophrenic angle is not obliterated on the right side, but there is a obliteration of the costophrenic angle on the left side. There is no costophrenic angle on the left side. The cardiophonic angle on the right side is also obliterated, but the cardiophonic angle on the left side is not also seen well. The cardiac shadow is also not well properly seen on the right side and also on the left side. So there is a and dome of diaphragm is not well demarcated. It is seen, but so it is taken in expiration time, and the right side there is patchy opacity throughout the zone 2 and zone 3. So there is a right sided pneumonia, bronchopneumonia, and the left side there is a homogeneous opacity throughout the zone 1, zone 2, and zone 3 also. Zone 1 also, zone 2 also, and zone 3 also. And the air bronchogram is there. So this is these blacks are the air bronchogram. The air bronchogram is there, and there is a and so this is a clear-cut diagnosis of left-sided massive lobar pneumonia involving the left upper lobe and the lower lobe also, with parapneumonic effusion, and right-sided pneumonia also, right-sided bronchopneumonia. So this is a clear-cut diagnosis of pneumonia. What are the differential diagnosis? There is no other differential diagnosis is there because it involves both the right and left side, but the left side is having lobar pneumonia and right side is bronchopneumonia. Why not? This is collapse of the left lung because the mediastinum is not shifted. The cardiac shadow is it is there, and the trachea is in the midline. So there is a no collapse or fibrosis is there. There is only pneumonia, and there is a parapneumonic effusion. Small parapneumonic effusion is there. The right-sided cardiac cardiophonic angle is there, loss. So this is shield heart sign is absent. Now next, so this is the scagram of chest taken in AP view, sorry PA view with proper exposure, and that there is no rotation is there. Clavicle is normal, the rib cages are normal, the trachea is in the normal position, the dome of diaphragm is normal, the costophrenic angle and cardiophonic angle on the both the sides is normal, and cardiac thoracic ratio is normal. No cardiac anomaly is there. The hilum region is normal, quite normal, but there is a mesh-like reticular opacity is present throughout the both left, right lower zone and also the left lower zone. So there is a reticular formation. So this look like a reticular mesh. So this is reticular mesh is look like with increased bronchovascular markings. So this is a diagnosis of interstitial pneumonia because there is a mesh like mesh-like opacity present throughout both the right and lower zone. So this is a interstitial pneumonia. And this is a diagram of chest taken in a PA view, which shows there is a homogeneous opacity on the right side, with a meniscus sign is there. This is a S-like meniscus sign is there. The costophenic angle and the cardiophenic angle on the right side is obliterated. Dome of diaphragm is not seen. There is no bronchovascular marking since, and the wide homogeneous opacity present on the zone 2 and zone. So this is zone 1 and this is zone 2. So zone 3, the homogeneous opacity is there, and also no bronchovascular markings is seen. No mediastinum is shifted. Trachea is in the normal position. Left-sided lung field is normal. So this is the clear-cut diagnosis of right-sided moderate pleural effusion or empyema thoracic or hydrothorax. White is due to fluid, and fluid is, there is a three differential diagnosis, either pleural effusion, hemothorax, or empyema thoracic. This is a diagram of chest taken in PA view, which shows there is a homogeneous opacity involving the right zone 2 and zone 3, and there is a radio-opaque shadow without any bronchovascular markings. Costophenic angle is obliterated. Cardiophenic angle is also obliterated. The zone and dome of diaphragm is not seen on the right side, and there is a straight, clear-cut horizontal line is seen between the radiolucent and radio-opaque areas. And so this is, and the upper zone 1 is showing there is a radiolucent area without any bronchovascular marking. The mediastinum is in normal position. The heart is in normal position. No shifting of the mediastinum. So this is a clear-cut diagnosis of either hydropneumothorax. This is a clear-cut diagnosis of hydropneumothorax involving the right-sided hydropneumothorax. Why it is hydro? Because this is the water and this is the air. So air and water making a area with a straight horizontal border. But if there is a fluid, then it is a meniscus sign is there. That means S-shaped concavity is there. Why? Because in my previous video, as I said, the X-rays go like divergent type. So it is a casting shadow effect causing meniscus sign if there is a only fluid. But if there is a air and fluid present in the pleura, so there is a clear-cut straight border between the air area and the fluid area. So this is hydropneumothorax. Now this is a skygram of chest taken in PA view with a normal exposure. No rotation is there. The clavicle is normal and the rib cages are normal. The costophenic angle on the left side is present, but the costophenic angle on the right side is obliterated. No costophenic angle is there, and the cardiophenic angle on the right side is not there. The cardiophenic angle of the left side is present, and left lung is hyperinflated, and the dome of diaphragm on the left side is normal, but the right side dome of diaphragm is not seen. The trachea is in the midline. There is a radiolucent area is seen on the right, involving the right zone 1, zone 2, and zone 3, and there is a white radio-opaque area presenting in the hilum region, that is, and no bronchovascular markings are seen on radiolucent area. So this is a clear-cut diagnosis of right-sided pneumothorax. Why pneumothorax? Why air is there? Because no bronchovascular markings is there, and there is a radiolucent area, and there is a collapsed lung. This white radio-opaque shadow is collapsed lung, because this is a bronchovascular markings is there, and this is a collapsed lung. So this is a tension pneumothorax. Now this is diagram of chest taken in AP view, which shows all the rib cages are normal, clavicle are normal, and there is the right sided lung field is also normal. The left sided lung field shows there is a chest tube in situ, and there is, otherwise it is a normal. The dome of diaphragm is normal. The costophenic angle and cardiophenic angle on the right side is normal, but the cardiophenic angle is present in the left side, but the cardiophenic angle on the Costopenic angle on the left side is obliterate. So this may be a diagnosis. This may be a diagnosis of pleural effusion with chest tube in situ or empyema thoracic with chest tube in situ. Where is the lung field? This is the lung field. This is the lung field. Now this is a scagram of chest taking in PA view with showing everything is normal, but the cardiac thoracic ratio is increased. So this is heart shadow, and this is A, this is the midline, A to B and C to D, and this is A and this is B. How to measure it? I discussed in my previous video. So A plus B plus C plus D by capital A B. The ratio is more than 50%. So this is cardiomegaly. Why this is not pericardial effusion? Because the angle is normal and the upper portion, the mediastinum, is wide. So this is not pericardial effusion. And now this is diagram of chest taken in PA view. We show massive increased cardiothoracic ratio, but the mediastinum is not wide. So this is a clear-cut diagnosis of pericardial effusion, and the angle is obliterated on the left side. Cardiopenic angle is obliterated on the left side, but the cardiopenic angle on the right side is there. So this is a clear-cut diagnosis of cardiac tamponade or pericardial effusion. Now this is a diagram of chest showing boot-shaped heart. Why? Because of the right ventricular hypertrophy. As I say, cardiac shadow. This is the right atrium. This is SVC. This is left ventricle. This is apex. This is right ventricle. As the right ventricle are getting hypertrophy, so their apex getting upwards. So it look like boot-shaped heart. And there is a oligemic lung. The bronchoscolar markings on the lung is decreased, and it is present only in the medial 1/3, and middle 1/3 is small. So it is like a diagnosis of tetralogy of Fallot or right ventricular hypertrophy. If the bronchoscolar markings is present throughout the lung field, then it is called top physiology. If the bronchoscolar markings is not there, it is tetralogy of Fallot. Now this is a diagram of chest showing there is a cardiomegaly with the mediastinum is not wide, and this is look like egg-shaped heart. So this is a clear diagnosis of TGA, egg on site. Why? In TGA there is a what happened? There is a egg on site appearance is seen. So this is egg on site appearance. So this is diagram of chest showing massive right atrial dilatation. So this is box-shaped heart, and this is box-shaped heart. This is Epstein anomaly. This diagram of chest taking in PA view, we show there is a cardiomegaly. So cardiomegaly is there. This is why massive heart, and there is a figure of 8. See, this is figure of 8. So this is supracardiac TAPVC. What is supracardiac TAPVC? I have described in my videos the what is supracardiac TPVC. This is TAPVC as because it increases bronchoscolar markings, and also there is a cardiomegaly. So this is TAPVC with supracardiac type. So this is all for chest X-ray. There are numerous chest X-rays there, but you have to know the basic of chest X-rays. So I discussed the basic of chest X-ray and basic most common things of chest X-ray. So this is for now. Thank you.